solving the mysteries in special situations, partial cuff tear, stiff shoulders, etc. So I request Dr. Arumugam and Dr. Mahesh Krishnan to chair the session and moderate. Thank you.
So we are going for an interesting session. A lot of controversy. Still, there is no right way about doing things on these topics. So I request Dr. Prakash Ayadurai to give his talk on partial thickness tear. Conservative always.
Good afternoon, everybody. Thank you, Shyam. Thank you, David Rajan sir. Thank you, Ortho-One, for giving us this opportunity. So we'll take the last commandment from Dr. Shirish Pathak's talk, that is doing no harm, and the top of the pyramid from Ashok's talk, that is keeping patients first. We don't have a perfect answer for this question, partial thickness cuff tear. So we don't have to do harm, so it is always better to conserve is what I think is the way. So we see by the way the conference develops that there is increased rate of shoulder surgery being done, and that adds up to the economic and social burden of the patient as well as the hospital care. So definitely non-surgical treatment always has a role, and it is sometimes a treatment alternative to surgical repair. This is what we have to remind. So partial cuff tear, when you see a patient with partial cuff tear with lot of pain, lot of night pain, discomfort, and you go to do an MRI and see a small red dot there on the footprint, is what you get. And is this the real cause for the problem, or is it somewhere else, is what we have to look at. What we see is pain, definite movement dysfunction in all these small tears. There are lots of suffering, and the problem that we see is a very small discontinuity of the tendon from its attachment, which is not extending more than 2 sagittal cuts. Yeah, that's almost always the problem. The incidence is largely unknown, but the partial cuff tears are somewhere around 13 to 32%, which is far more ahead than the counterpart of full thickness, which is 19%. Articular surface tears are 3 times more common than the bursal surface tears, and most commonly the articular surface tears happens in athletes, and if athletes comes with this problem, then 91% of them have partial tears, and all of this happens in the internal attrition zone 3. I'll tell you what it is later. So what we fail to recognize is there can always be a proximal nerve root pathology in these problems. There always starts with an internal impingement, leading on to muscular dysfunction, thereby giving a scapular dyskinesia, and then this kinetic chain link from the contralateral glutes to the scapular link should always be borne in mind. So partial cuff tear, we know it can be a bursal sided tear or an articular surface tear or intratendinous tear. Hellman gave us this classification: if it is grade 1, if it is less than 3 millimeter, grade 2 if it is 3 to 6 millimeter, and grade 3 if it is more than 6 millimeter. Also depending on the thickness of the tear, if it is more than 50%, it is grade 3. The area of interest here is partial articular intratendinous tear, which is another subset of partial tears. This is being most commonly recognized on non-treated partial articular surface tears, which extends onto the intratendinous aspect, and it is very difficult to treat conservatively. So evidence 1 of our understanding is the supraspinatus has 5 layers. The topmost layer is the superficial fiber of the coracohumeral ligament. The second layer is the closely packed parallel tendon fibers, that is the bursal surface of the supraspinatus. Coming from down, the layer 5 is the capsular layer. Layer 4 is the deep fibers of the coracohumeral ligament, and layer 3 is less uniform fibers. So by this we know that layer 3 is not having good amount of collagen, and that's probably one of the reasons that it could fail conservative treatment. Whereas type layer 2 or the bursal surface tear, sometimes when it is partial, it can heal well because one, it has good stem cells like discussed already, and also it has got closely packed parallel tendon fibers which are amenable to conservative treatment, and probably when you do good mechanomodulation, it can heal well. Coming on to vascularity, the bursal surface is richly vascular, articular surface is poor. The vessel, when you see these images, you see the vessel decreases from proximal to distal. It comes down when it comes to the articular surface, and most of the vascularity is in between the layer 2 and layer 3. You see a good vasculature on the bursal surface. Location of these tears are always near the biceps, posterior and medial to the biceps, not extending. I've never seen literature describing partial articular surface infraspinatus tear. It is always the supraspinatus tear. How does that happen? This happens because there is an internal impingement mechanism that is happening on the posterosuperior labrum that causes this biceps to hinge onto the supraspinatus. That's the posterior pulley of biceps causing these tears. Of course, by this repeated mechanism, there can be a lot of changes that can happen. There can be fatty infiltration, degeneration, loss of matrix organization, which is important. Increased vascularization, meaning increased inflammation meaning more pain. Also, there is always, if there is chronic muscle fatigue in repetitive movements, especially in athletes and old individuals, there is inactivity. There is a difference in the efferent pathways. There is decreased proprioception, leading on to focused load onto the anterior aspect of the supraspinatus, and then that is where the tear is. When you look at this single 3D motion measurement, you see at 0 degrees there is some activity at the tendon level of the supraspinatus, infraspinatus, and the subscap. Whereas at 30 degrees, you start to see the superior aspect of the subscap getting loaded and the biceps area getting loaded. That is where there is problem. So this is the finite element analysis done by this group. Found out that there is lot of pressure on the anterior aspect of the supraspinatus because of the mechanical load. So there was an experiment that was done. This is very, very important to know that fatigue equals failure. So they placed surface EMG on two group of peoples, and then they fatigued the infraspinatus to find out the impingement promoting activity after fatigue. So if there is a problem, if there is muscle shutdown, and if there is secondary fatigue, what happens is there is too much load on the supraspinatus, and probably that is where it fails. So either by seeing an MRI and treating the pasta lesion or a bursal lesion, we can go proximal, retrain the muscle, rework the muscle, and bring it back to normalcy, thereby by mechanomodulating, inducing tear. Also have to remember that these two go hand in hand. C4, C5, C6 nerve root, if there is a problem, there is 1.5 times more risk of this patient developing a rotator cuff tear, and this should not be forgotten. Conservative therapy, there are NSAIDs, the first line. You can use modalities like laser or shortwave. Injection therapy, of course, you can use steroid, PRP, or prolotherapy, and mechanotherapy as an exercise. I'll give one classical example for everything. We all know there is a lot of thing about steroid versus PRP. Here, the evidence suggests leukocyte poor PRP is better, and always when these are compared with steroid, PRP does well in more than 6 months, and there are no good studies which are extending more than 6 months. Probably they're losing follow-ups. Again, steroid versus PRP. This is this paper that says there is reduction in tear size after PRP. I don't know how, but both these groups did have home-based physiotherapy. That has to be borne in mind. So here again, non-operatively, will this heal? This group of people were given home-based exercises, non-supervised, and then this is a 65-year-old female, bursal side almost a high-grade partial tear, which there is tear progression. This is not again, there is tear progression. Again here you see a 64 male with a bursal surface tear, which has completely healed well in 2 years. Again, there's another example of an intratendinous or a pasta lesion, which is completely healing after treatment with physiotherapy alone. So after you do a bout of therapy, does this tear progress? Of course, more than 18% progress on to become a complete tear. And what are the subset of people that go on to tear progression? If they have a bursal surface tear, if the tear involves the dominant side of the shoulder, or if the depth of the tear is more than 50%. There is a universal consensus that you can try physiotherapy for around 12 weeks or conservative therapy for 12 weeks, not more than that. And who will respond well is explained terrifically by Tanaka. If the patient has preserved range of movement in external rotation, if he has negative impingement sign, if he has little or no atrophy of supraspinatus muscle, if he has a preserved intramuscular tendon of the supraspinatus, this patient, if they have 3 or 4 factors, there is 87% success rate in conservative treatment. So it is better you understand your pathology, open your mind, keep continuously motivated yourself and the patient, do intervention very minimal only if required in these problems. EMG can help, it is ECG for like ECG for your muscle. There is always some of small gains when you do physiotherapy. Of course, if all these evidences fail, your boss is always right, do what he says. Yeah. So rehab is a wonder drug. Conservative therapy is cheapest and safest, and it almost always works in past the lesion. If it doesn't, what is there? You can go ahead and do surgery. Yeah, thank you.
Prakash, excellent histopathology, etiopathogenesis of partial cuff tear. I think audience delegates will have a lot of questions as to when and how you convert a conservative to surgery in partial cuff tear, which will be addressed later. Now I request Dr. Subramanian sir for partial cuff tear. I operate always. The fight starts here.
Thank you, chairpersons, and thank you, Ortho-One team. I think Prakash has given full explanation. How will you treat? And I did not mention my heading saying that I always operate. I said I fix it. Okay, because many times I fix it with rehab itself. First thing is, I will tell some salient points which is very relevant to the partial cuff tears. One has to understand what is partial cuff tear means, because if you see the cuff attachment, the dimension is 13 to 33 millimeter. So someone who has got a tear up to about 12 mm will still be called as a partial cuff tear only. Though it is extending up to 12 mm, it will be called as a partial cuff tear only. Next is not a single disorder, it's a spectrum of cuff disorders where it extends from tendinosis to intrasubstance tear and then a partial tear and then becomes a full thickness. It's a spectrum of a same disease which is seen at a various presenting levels. And you know this classification, so I am not going to tell it again. So, and the incidence varies from 13 to 32%, which means it's seen in a lot of asymptomatic patients. If you do MRI on a lot of patients, you might find partial thickness cuff tear is a coincidental finding. So, it may not be symptomatic at all. In about 32% of patients in the 7th decade of life, you will see a lot of them have partial thickness cuff tear. So, it may not be a significant point at all. So, which is significant for us is someone who is getting traumatic tear. And due to proper trauma in a young athlete who has got a partial, that's what is important for me in terms of fixing it. So the problem in a lot of patients is lack of vascularity, which is coming around the age of 40 or 45. That's the age where they get lack of vascularity, and that's where they start getting the partial thickness cuff tears. This is a very important thing I want to emphasize. So this is taken from our own paper, where the scapula is anteriorly tilted in many patients. At the age of 40, they start developing the stooping posture, which tilts the scapula anteriorly, which automatically what happens, the subacromial space becomes narrow. That is the main reason for them having the pain and starts getting partial thickness cuff tear. This picture is there in Journal of Clinical Orthopedics in paper written by us, where you can see that scapula anterior tilting causes reduction of subacromial space. So if you work on these 6 muscles, trapezius, levator scapulae, serratus anterior, and lat dorsi, rhomboids anterior major, this anterior tilting of scapula can be corrected. The patient's pain will get relieved. That is the most common physiological mechanism which explains how the symptoms get relieved by doing a rehabilitation very properly. This patient has got a impingement positive, scapula is elevated. Each time he's doing it, you will do this, he does this, there is anterior tilting of scapula. So after doing the rehab for about 6 weeks, that the scapular anterior tilting is gone. The simplest way of treating a partial thickness cuff tear is by doing a proper rehab that they will get relieved. So another way to assess whether our rehab is going to work is by doing a scapular assistance test. In this patient, I am trying to push the scapula to correct the anterior tilting and see whether the impingement disappears and the pain gets improved. Then it indicates to me that in about 6 weeks time or 8 weeks time, if I do a proper rehab, his pain will improve. This is the most common scenario in where you can do, most of the patients can be treated by rehab itself. So where I do repair? Now the question comes, okay. Failure of conservative management. And there is many articles are there about it. You have to do conservative management for all these partial cuff tears for about 6 to 10 weeks. And if they don't get good relief of symptoms, continuous pain and difficulty in movements, then you go for repair. Where you occur is more than 50% involvement of tendon, and in young athlete where they have a traumatic history and coming with severe pain, there you consider doing a repair. So I'll give 3 case examples which will completely explain which kind of scenario where you are going to do repair. So first scenario is a gentleman 28-year-old who is Hawkins positive, who has come with a severe pain. He is an athlete, who has got severe pain in the shoulder, and there is an acromion spur also. And if you see, MRI is showing a bursal side tear, which is almost like a near complete bursal side tear, but it's not fully complete. And if you see the arthroscopy picture, there is a big spur. So after doing the excision of spur, you can see that there is a small tear which is almost like a crescent shaped tear, which is not really extending down to the articular side. It's a bursal side partial tear. We see the picture intraoperatively, you can see that the tear is not going beyond the articular side. It's just stopping over the bursal side only. This is a place where you can think about, it's a young person, athletic person, where you can think about doing a simple bursal side only repair of the tendon without even going to the articular side at all. So what we have done is just like doing a simple repair, the knotless technique, putting a knotless anchor. This is a typical indication in a young athlete where you see only a bursal side tear without extending to the articular side. Then you can think about this kind of knotless repair. A simple one, it preserves a length tension mismatch that can occur with any cuff tear. You can get length, and this can be preserved in this. So another case 24-year-old athlete, pain in the shoulder for 3 months, clinically is Hawkins positive. It's got a PASA type of lesion. There's a PASA type of lesion, partial articular surface tendon avulsion. So if you see intraoperatively, what we have done is repairing only that articular surface tear. So you put the anchor in the place where there is some cartilage, the muscle loss, and try to repair through the transcendinous repair. This you do it in selective cases where you see in athletes where there is only a PASA lesion, and to preserve the length tension relationship we can do that. But this patient has got a PASA lesion where you can see that cuff tear is there in the articular side, and there is fraying of that. It's only that layer 4 and layer 5 gets ruptured in this. And freshen the edges, make sure that the bone surface has been well seen, and freshen the bone bed, and use your owl transtendinously and put a anchor through that. You're just trying to freshen those. So this is in patients who are around that young age group where you want to preserve that athletic function. That's where you're trying to do all these things. And after putting anchor, use your spinal needle to pass a proline or a ethylon, and then retrieve those suture material through that and tie it on the subacromial side. So this is the transtendinous repair where you are doing it, try to put 2 spinal needles and pass a proline and retrieve that suture material along with the proline by a railroad technique, and so that you will have those 2 suture materials coming to the subacromial side, and then you can either have 2 scope or you can switch your scope to the subacromial side and then do the tying of the knot on the subacromial side. Usually we do with only 1 scope, so you have to keep swapping from one end to the another end to do the transtendinous repair. So these are the 2 techniques you have: transtendinous repair and making the tear for a bursal side as well as an intraarticular side. So last is a case 3. This is a patient who has got a traumatic cuff tear, but has got a near complete tear, and he is a young chap. And this kind of scenario, what you do is complete the tear fully and do a full robust repair. When you do a full robust repair, then they can have early rehab. So traumatic near full thickness tear, you can go for almost like complete the tear fully and do a full complete repair, so that your articular side and as well as bursal side is repaired near anatomically. That will be the way forward for those kind of individuals. So I am going to tell about rehab is the first choice of treatment for almost all partial tears, but repair is for failure of rehab, and that is the indication for repair. And the 2 techniques are tear completion and repairing or transtendinous repair. Inside to repair preserves the length tension relationship. Anatomy is almost near normal. Preferred technique in younger athletes. Technically demanding, but stiffness is there about 12% quoted in the literature. Same thing if you do full completion of tear and doing repair, we'll almost do the robust repair. Still the stiffness incidence is little lower, but still it can occur about 8%. The take home message is surgery is indicated when conservative treatment fails. For partial thickness tears involving less than 50% of tendon thickness, debridement may be alone, may be needed. only if the conservative treatment fails. If more than 50% tendon thickness, then you go for a repair, either in-situ repair or a completion tear and repairing it. Few available studies in the literature showed similar functional structural outcome between the in-situ repair and repair after conversion to full thickness tear. I think it's almost like a personal preference what you want to do. But I prefer to do the in-situ repair only in those young athletes. During long-term follow-up, arthroscopic in-situ repair of articular and bursal site partial tears showed excellent functional outcome in more patients with a low rate of revision. With this, I thank you that. For those who want to read more about it, you can read on this article which we have written it and published it. It tells almost everything about partial thickness tear and full thickness tear. Thank you very much. And I invite every one of you for Oasis knee count, which is happening next month, June 24-25 at Madurai. It's only focused on knee. So please get registered for it. And you can do abstract submission for free papers also. And if anyone not member of Indian Arthro Society here, please do become Indian Arthro Society member. Please make it soon. Thank you.
Thank you, Dr. Subramanian, for a very instructive nature of lecture. I'm sure there will be more questions. Will be taken at the end of the session. So I request now Dr. Sundararajan to give another difficult problem for
Good morning, everyone. So I take this opportunity to thank David Rajan sir for having me here, and also Shyam, Sandosh, and whole Ortho-One team. And I'm also honored to operate live surgery in Ortho-One Hospital. And also I request Shyam to include me in Ortho-One alumni, because I also learned all my basic techniques with David Rajan sir. But I had a privilege of learning in Ganga Hospital itself, where sir used to come and operate in the, long ago. Probably many of the delegates may have been in a LKG, UKG, or in an elementary school. Thank you. So my topic is on a stiff shoulder. I think, so I'm going to cover the two parts. One, I think all of you know that the terminology of stiff shoulder is very broad. And Issaquah's Upper Limb Committee has chosen the word like a protrusion shoulder rather than adhesive capsulitis, because there is no proper true adhesions inside the joint. So when you talk about the stiff shoulder, we are talking about one is the primary stiff shoulder, which is going to be my first half of the talk. Second half of the talk, which I was asked to talk about stiff shoulder with the cuff tear. That is the secondary cause of your stiff shoulder. So I think most of you know the stages of adhesive capsulitis. I think we know that the freezing, frozen, and thawing, where the freezing stage in the first 2 to 6 months, patient used to have only pain. And the second stage, when it goes for frozen, then it used to come with the pain and stiffness. And the last stage is the thawing, where the terminal stage, patient can present with only stiffness, no pain. But most of us know that many of the patients will not come to that last stage, because patients need intervention. Patient cannot wait for 26 months. And very few patients I see only with the stiffness without any pain. That means they're all in the frozen stage rather than the last stage, thawing stage. And if you see the traditional treat of treating these cases are conservative management for the both freezing stage and the frozen stage in the form of steroids, oral NSAIDs, and intra-articular corticosteroids, physical therapy. And mostly the advised surgery only in the thawing stage, that is capsular release or MUA, when they come to the thawing stage. But I think many patients don't have the patience of waiting for 12 months to 24 months to get operated or do a manipulation or anesthesia. So many of the patients get operated or do a manipulation in the stage of thawing freezing itself. I also do that, because patients lose the patients, and it's very, very difficult to do the rehabilitation with pain. Even with the supervised physiotherapy, it is very, very tough. So that's why we try to intervene a bit earlier than where you see the thawing stage. What is the role of steroid injections in these cases? Whether to do an ultrasound guided or a blind injections, there is no major benefit as by the literature review. What to do whether intra-articular or subacromial? Even the subacromial increases the movements, but intra-articular, they says that gives a better pain relief than the subacromial. What to use, whether to use a methylprednisolone or a triamcinolone? Literature has shown that triamcinolone has got a better effect than a methylprednisolone. You can use a 20 milligram or a 40 milligram. Don't use a 10 milligram, that may not be effective. You can use a 20 milligram or a 40 milligram. What happened to the hydrodilatation? Few surgeons practices this procedure, hydrodilatation, where you inject the saline and distend the joint for the pain relief. Some literature had shown that with very good results in the short term. You see that it appears to be maintained for 6 weeks, not for the long term. And if you see the comparative study, that's an RCT double-blinded between the steroid and the hydrodilatation with the steroid, where they said that doing a hydrodilatation has got doesn't have a much advantage in doing this procedure with the steroid injection. So if you are tried everything, then what next? Then whether you do a manipulation under anesthesia or you do an arthroscopic capsular release. What the literature says in the manipulation, patients, there are some studies where you can set up to 15 years follow-up. It's on another 19 patients published in JSAS long back with very good results without any complications. And this is another paper where they did a manipulation, then did an arthroscopy. I think this paper has changed the surgeon's practice, where they documented like slap tests, subscap tests, 3 anterolateral tests. That resulting in people started doing more arthroscopic capsular release rather than manipulation. But it is a very good advantage because you are seeing under your vision, you are doing the controlled release. But it is an invasive procedure, as all of us know. So what happened to the long-term results of arthroscopic capsular release? They are very good results, and functional improvement equal to the almost opposite side. That is the shoulder, not the knee. So this is another paper, it's a systemic review of published in 2021 with the 18 articles, where they found that what kind of release had to be done, only anterior release or anterior with the posterior release or a 360-degree release, where they found that less extensive releases gives a better functional and pain score. Doing a 360-degree release may not have a much advantage doing these releases. What happened to the manipulations versus ACR? There are very limited evidence available in the literature. This is another paper on systemic review in 2013 published in Journal of Shoulder and Elbow Surgery, where they found there is no clear difference between range of movements and functional outcome with both these procedures. And you see the complication rate, it's not a huge difference between these two. The another Frost study, I think most of you know that it was studied between the steroid injections, MUA with the structural physiotherapy, where it was done in the 35 centers with so much 503 patients, where they found that there is no huge difference between these procedures. However, if you see the complications, arthroscopic capsular has got more than MUA, and there is post cost-effective intervention in that all the 3 is manipulation under anesthesia. And this is our paper which was published in 2022 with International Orthopedics, where we did a randomized study between the MUA and arthroscopic capsular release, where we could include 44 and 41 patients in each group. If you see the movements, the arthroscopic capsular release had given an earlier movement, improvement in the early stages, but in the late stages, it's almost equal at the end of the 1 year, and there is no significant difference. Even though preoperative MRI showed some tears like these pasta tears or the interstitial tears, they didn't have any complications when he did a manipulation. So we didn't have any progression of the tears. Even though that many patients had a capsular tear and labral tear in the MRI, which we did after 6 months, but all of them are clinically silent. So we concluded that both ACR and MUA are equally good results with both functions and also the pain relief, but a simple technique and cost effectiveness, still MUA an attractive option for the frozen shoulder. A take-home message is that both MUA and ACR has equal results, but stepwise MUA keeping in a short lever arm minimizes the complication. Lesser cost, non-invasive nature, still is MUA is another option for you. When you come to the rotator cuff with the stiffness, the prevalence is around 12.1 to 41%. And we know that always managing this rotator cuff needs long rehabilitation for healing, but when you do a stiffness shoulder, then you need an aggressive rehabilitation. So you have to balance both. That's why the controversy comes. But I think nobody waits for the stiffness to go and to do a cuff repair because it's long time. It is very, very difficult to do that. And there is no, this is the paper as done between the non-stiff group and the stiff group published in JS, and no statistical difference between these two groups. The only thing is this is systemic review. They included many studies, but there is no group matching. There is no group matching for the cuff tears or age. But however, they found that re-tears are slightly less in the stiff group rather than the normal group. This is one of our analysis is between 2017 to 2021. And our group, which we could include group 1, that is stiffness group, is around 33. And propensity matching, which we had a group 2. So what do you mean by propensity matching? Like we could match the age, duration of the symptoms, diabetic status, body mass index and size of the tear, so that we could easily, you can match both the groups in the similar way, which you could get 33 and 60, but that is 1:2 on this. both. And we did an MRI studies of after 6 months for all these patients to assess the healing. And this is the propensity matching. And you see that outcome after the end of the 1 year or a final follow-up, there is no huge difference in the rotations, both internal and external rotations, and also the functional scores of constant and the ASES. And you see the retear, which we also found that there is slightly less in the stiffness group rather than our control group. And to conclude, we found that in single-stage arthroscopic repair and concomitant release of rotator cuff tears with stiffness results in a good clinical and radiological outcome. The good outcomes of concomitant treatment of rotator cuff tears with stiffness suggest that there is no advantage in delaying the surgical repair of a rotator cuff tear until stiffness resolves. Thank you very much.
Very extensive, informative talk by Dr. Sundar. He is the right person to talk on that because he himself has studied extensively on the stiffness pattern and different modalities of the treatment. Definitely we'll have a few questions to ask him at the end of the session. Next, I invite Sujit Jose. How we manage the BOS? Don't forget the BOS, subscapularis repair, the significance of subscap repair. Over to Sujit.
Yeah, good morning. That is an interesting heading given by Dr. Sundar. Thank you. First of all, let me thank Dr. Devarajan sir, whom I've always looked up to as a budding surgeon when I was very young, and Dr. Sundar on the team, Dr. Santosh Sahanand and the team Ortho-One for organizing this conference and allowing me a chance to operate on a patient here. My privilege. And let's talk about subscapularis. Subscapularis is one tendon, even now is a forgotten tendon by most arthroscopic surgeons, just because it is difficult to diagnose arthroscopically as well as radiologically. Even the radiologists miss the subscap and say it is just a partial tear, and we prefer to listen to it as a not a significant subscap tear, so that because it's slightly difficult to do. It's called the hidden lesion as it is in the articular surface. Unless you view from the intraarticular posterior portal, you may miss it sometimes. So, but then over a period of time, better understanding of the anatomy and biomechanics and combined with newer imaging modalities has made us more to diagnose more of subscap tears and repair them. The tears of subscap were first reported in 1834. Surgical repair was first done by Hauser in 1954 by transosseous tunnels lateral to the bicipital groove. It was not until the major series by Gerber and Kerschel in 1991 that the focus was more put on the anterior rotator cuff, that is the subscap and the anterior cable of the supraspinatus. So why the BOS? It functions as the internal rotator, as a stout rolled border of the tendon superiorly, as we saw in the first surgery, onto the superior portion of the lesser tuberosity, and the bulk mass is more than all the three other rotator cuff muscles combined together. You can very well see there, that is a subscapularis. The insertion on the lesser tuberosity contains both a purely tendinous part as well as a muscular part. In cadaveric studies, the tendinous portion was found to be about 2.5 centimeters into 1.8 centimeters. It's a big footprint, and it is bigger than the supraspinatus and infraspinatus footprints. So it's a big, massive tendon which has to be addressed for the shoulder to function normally. So even without a supraspinatus, the shoulder, the patient may be able to compensate for absent supraspinatus, but not for absent subscapularis. That is what the importance of the subscapularis is. So it's more seen in males rather than females. There might be history of forced external rotation when the subscap tears off. Isolated tears are often traumatic and be seen with glenohumeral dislocations. Most commonly present in conjunction with an anterior supraspinatus or anterior structural rotator interval tears, or with large multi-tendon tears. I've seen tears with subscap, supra, infra, and teres minor all together, all the bald humeral head. You have to reattach all to get a good result. Tendon degeneration is seen with the same rates as with superior and posterior rotator cuff tears. So what are the tests to diagnose subscap? The lift-off test of Gerber, the belly press test, the increased passive external rotation when the subscap is not there, or the bear hug test or the resisted internal rotation test, which can give you an idea about the subscap function. That's what the MRI shows of subscapularis. You can have a bridging sign where the posterior supraspinatus and inferior subscapularis may be intact, and you may see a bridge of area where the tendon is intact, more medially into the joint. Ultrasound can diagnose subscapular. You need to be trained in that. You can see the subscapularis very well detached from the lesser tuberosity, and the biceps long head, which can subluxate it down. We always look at the bulk of the muscles, and you can see the atrophy of the subscapularis in a chronic tear and a bare lesser tuberosity sign. MRI appearance, in axial views, you look at the subscap. These are the various types of tears. When you see the biceps tendon here lying there, you always know that the subscap is torn, at least the articular surface. So that's a normal subscapularis, and that is an atrophy of the subscapularis, which may need to be addressed or checked properly before doing a repair or doing some augmentation procedure. So subscap tears commonly start on the articular surface. It may be partial, and the biceps tendon can sublux into this area. So that's a normal subscapularis tendon. That is a comma sign, which I could demonstrate in the morning, and that is a forelock sign. That is a partial articular surface tear. You can internally rotate the hand and see the tendon coming off from its footprint when it's torn more, or a airbag sign where it can be ballooned up there, or the sentinel sign. These are the arthroscopy signs of a subscapularis tear. Classification, Lafosse classification, we were all talking about from morning. Type 1 is a partial upper third. Type 2 is a complete upper third. Upper 2/3 tear is a Lafosse 3. That is what we operated in the morning today. And that is a whole subscapularis tear, but without much of fatty degeneration or subluxation of the head. 5 is when the head subluxes anteriorly. That is a J.C. Lewis arthroscopy footprint classification or nomenclature, F1, 2, 3, 4. These are the various areas of attachment of the subscapularis. Treatment, general principles, less than 50% cuff tears, you go conservative. If it fails, you can think about a repair later. Acute traumatic tears are better treated surgically as per available literature. Arthroscopic treatment yields good results. It gives good access for mobilization, and coracoplosty can be done if needed arthroscopically. So B-chair position we've already seen. High-grade partial tears you can visualize from posterior and repair from anterior. Or a complete tear, you can go from the top, that is visualizing from the lateral portal, and repair from the anterior biceps portal. Important structures to be careful there are the musculocutaneous nerve, the brachial plexus lateral cord, the axillary nerve and artery, but they are all about an inch medial to the coracoid. So stay adjacent or lateral to the coracoid, you are safe. You cannot injure any structure. So that is a subscap repair, as we saw in the morning, an anterior portal repair. You're using a Mason Allen stitch. Mason Allen is 2 mattress sutures and 1 symbol suture. The mattress is tied first and the symbol is tied over. So it forms like a cross and it holds well. It is a very good type of stitch to learn in arthroscopy. It can be used in various scenarios, even in supraspinatus. That is a repaired subscapularis. Again, that's a Lafosse 3 type of subscap tear. You can see only the inferior part is intact there, and the subscap tendon, you can see the tendon anteriorly and the bare lesser tuberosity sign. So that's a double row repair. We are viewing from the lateral portal, the grasper going in, that's the left shoulder, the subscap tendon being pulled on to the footprint there. And I do a Mason Allen stitch, a crimson duvet for increasing the vascularity. So 2 sutures made and a lateral row anchor to complete the repair. We are viewing from the lateral pole, that is a tendon in place. So medialization, you can go up to 4 to 7 millimeters medially. A case of a 44-year-old businessman who was operated for a rotator cuff tear, that was what the report showed, a partial tear and tendinous subscap. The surgeon fell for it. He did supraspinatus repair alone and left the subscap there. At 5 months, he came back with a drop arm sign positive, and there was a sudden loss of power. You can see that the subscap is detached here, and the anterior tendon avulsed, with the supraspinatus which has retoned. So you can see the re-tear in the supraspinatus, and that was a pre-op. Looking at it retrospectively, those were the MRI images. You can see the supraspinatus. This was the image before the first surgery. You can see the subscap is very well toned there. Can I take 20 seconds more? So that was the tissue which fooled the surgeon. He thought it was the subscapularis, but then when you pull the tendon, you can see that is the bulk of the subscapularis which comes in. That was what the boss was doing. So you failed with the boss, and that is the problem which happened. So irreparable subscapularis tears, you can do a tendon transfer with a pec major or a pec minor, or allograft reconstruction. Older patient, you can with arthritis, you can think about an RSA. That's what RSC is about. And take home, subscap has an important dynamic function in maintaining the transverse force couple. The infraspinatus superior end and the superior end of the subscap are important tendons. Why the boss we already discussed, it's bigger and the footprint is much larger. Arthroscopy repair produces reproducible results, and single row, double row is a surgeon's choice. Thank you.
Thank you, Dr. Sujit Jose. Excellent lecture after excellent demonstration in the morning. This session is open for discussions and questions. So encourage from the...
Sir, for the benefit of the viewers, the order of fixation when you come across a massive supraspinatus, infraspinatus, and a subscapular, what is the order of fixation and why?
The first idea is to centralize the head. So I would prefer the subscap be put back first before you embark with the supra and infra. So you put the anchor in, insert the anchor in for the subscapularis, repair it well, do the tenodesis of the biceps if required, or the biceps can be used for anterior cable augmentation. Then anchor anterior, anchor posterior, but tying from posterior to anterior again. So anterior cable you have reconstructed first, then you start with the posterior cable and then go for the supraspinatus. That is the order I would follow.
But with respect to once we finish the cuff repair and seeing the reddish inflamed capsula, the ligamentous structures like the MGHL, the rotator interval, what is the incidence of post-operative stiffness that you come across following a cuff repair like this massive?
If the rehab is good, unless the shoulder was preoperatively not very stiff, it was a stiff shoulder we are operating about, Dr. Sundar rightly said, we do a release and do a cuff repair later. That is a right way to go forwards. But if it is not that stiff shoulder, without that much of inflammation, the inflammation will settle down.
So there is no need for a prophylactic release?
You have to do a release in a chronic cuff when the cuff is retracted.
Yeah, what I'm saying is the anterior release, the MGHL, the IGHL release, when you suspect that this is going to stiffen up during the rehab phase?
I don't do a formal release in a short or a subacute scenario. In a chronic scenario, when it's retracted, I would use a traction suture and do a release unless it is not coming onto the footprint.
Okay.
Otherwise, a formal release is usually not required because it will settle down. The shoulder is angry because of the instability. It is in dysfunction. Okay. The anterior superior tear is actually causing a subacromial impingement, and that is the reason for the inflammation, which will settle down with good rehab.
Knowing the significance of the Kama tissue, when do you preserve it? When do you sacrifice it?
In a acute scenario, I would just go ahead and do a repair. The Kama tissue is preserved. In a chronic scenario, I would freshen it up and do a repair.
Thank you.
There's a question from the audience.
Okay. My question is to Dr. Prakash, which is in partial rotator cuff tears, which is the best view? Is it a PDFS? Which is the best sequence? Which is it a PDFS? Is it a T2 sequence? I'll give you a scenario also. Yeah. A patient with shoulder pain, I've advised an MRI for the patient. The report is the cuff is normal. But when I see the PDFS image, I can see that there is a partial tear. I call up my radiologist, who himself is a musculoskeletal radiologist. I tell him, boss, I see a partial tear in the PDFS. Please change your report. It will cause me trouble with the insurance. Then he goes and looks at his images and he says that, boss, no, this you check T2, it's not there. It is because of magic angle artifact that you are seeing that, and it's not there in T2. I can't change my report. So a tear that is visible in T2 or PDFS, which one would you consider a partial tear? And your opinion about this magic angle artifact?
I've heard about magic angle artifact only in ultrasound. I've never heard of it in MRI, and I would always look at T2 because that is how we are trained to do, and that's my answer.
We generally tend to look at PDFS more because the
contrast
is much better.
That was a question better answered by Dr. Murugan in the morning, the radiologist, not by Dr. Prakash, it seems.
We also by the T2 image for surgeons. But
T2 or P2.
Dr. Subramaniam. Dr. Subramaniam.
No, let me answer here.
Yeah.
I think the basic thing is whether it is T1 or T2, the ligament tendon will always look black in MRI. If it is looking either slightly grayish or whitish in T2, then you consider it as some kind of tear or some abnormality there. Okay, so I would look for T2 mainly. T2.
No, not PDFS.
And more than that, you have to look into number of slices. It's not, if it is only one slice, is usually about 3 mm. Okay, if you are seeing in about 3 slices, it means about 9 mm of tear is there. So you need to see how many slices you have the tear. That's also important.
Magic angle phenomena is more with the
one
T2
question,
it seems.
One question to Prakash sir. Suppose a 50-year-old gentleman, similar history of fall, and is able to abduct the arm with difficulty and with some pain, and the MRI shows a partial bursal-sided cuff tear. So you are going to start on conservative management. So is there any role for immobilization in the initial 1 week period? And how do you do the conservative management? Do you start on mobilization, or when do you start the
There is
strengthening?
no role for immobilization, because the more you move, the more the tendon adapts and more growth on that particular area. So immobilization has not got any role. But if you're asking me how to start with physiotherapy, I think if the patient is having pain during initial motion, then I think eccentric exercises is better than doing contraction, isometric exercises there. So if the patient, you can start with eccentric exercises. There's a concept called optimized loading for better growth. So optimized loading, they speak about eccentrics more. So you don't have to immobilize, and you can definitely conserve that patient.
The same patient, after 6 weeks, is able to lift freely, but the pain is still there. So how do you do about that?
But we have to look at the patient as a whole. What is the problem that is going on with the patient? If his scapular rhythm is got back, doing physiotherapy is not sending to someone and then not knowing what is being done. If the scapular plane is being brought back to normal, if the scapulothoracic kinesis is normal, if that is normal, then you have to leave the patient. That he might get better. If not, then try other modalities like injection or something to augment your physiotherapy. Don't have to go and do repair straight away.
Okay. Yeah. So your decision on whether to go in for surgery or
definitely at least 12 weeks of
12 weeks.
Beyond 12 weeks. Yes. Yes.
If I can add on to, sir, in the radiology, I think it's a good choice to see the sections, not least Sag, coronal has to correlate. And because if you've seen 2 sections, I think you can appreciate it better. And that is, I think, better way to correlate. Sag and coronal, you should have the same kind of images, and we should be able to pick up the images in both sections. Then I think it is more of a tear than anything else.
If it is that small a tear, does really require intervention? Yeah. No. If you're not able to pick it up in
definitely no. Okay, but that means I just talk about the radiology part. That means how to pick it up. If there is a confusion, if there's a tear or not. So the best way to is both in the Sag and coronal should be correlated.
Correct.
So in short, can we say that assessing the tendon quality, T1 and T2 is better? That's it.
Also go back to ultrasound and find out if there is a problem. Yeah.
Correct.
One more question.
Hello. Hi sir, my question is to Sujit sir. Sir, as a beginner, I have always wondered what is this coma sign. You told how to identify the coma sign arthroscopically. I mean, you told you will repair the coma sign in chronic tears. Just now you told in acute tears you will leave it like that. So how to identify? Is it an anatomical structure or we are attributing to anything?
Now, when you view from the posterior portal, the soft tissues which attach to the upper part of the subscapula, that is after it has torn. So that is a coma. So you have to just, in a chronic scenario, I just clean it and reattach the tendinous part. The idea is to put back the tendinous part where it is supposed to be.
So sir, it's a cable like it goes from upper border of subscapularis.
Yeah, it's not a cable, it's just an anatomical structure. You see, it's a sign saying that the subscap is torn from its footprint. When the tendon comes off, it comes with a soft amount of like fibrous tissue or a synovium, which looks like a coma, that's it.
It's actually a condensation of tissue.
Capsule condensation?
Yeah, it's a capsular condensation of the anterior part of the supraspinatus, upper part of the subscapularis, SGHL, and outside the capsule, CHL. This marks the suprolateral border of the subscap. It has also attachment to the anterosuperior border of the supraspinatus. This is actually a functional connection between the subscap and supra. When the subscap's full thickness is torn, this capsular condensation is torn off from above and looks like a coma above. This is an anatomical structure which is viewed arthroscopically.
In arthroscopically, it can be called the bridging sign.
Bridging sign.
Okay. When it's continuous from the supra to the subscap.
Okay, thank you sir.
Just a finding telling you that there is a subscap tear.
Already Magesh told everything.
Yeah, a question to Sundar. When you do a selective capsular release, in contrast to the 360-degree capsular release, which is your order of release, or which all preferentially you release in a established classical frozen shoulder where the movement is 100, 100, 45, L5?
Yes, a selective release, usually we do the only rotator cuff interval release, anterior and anterior inferior. We don't do the posterior, or I don't remove the biceps, I don't do the 360-degree slap. So mostly I do only a selective release, that rotator interval, anterior and anterior inferior. Regarding that comma tissue, which I want to again tell him that it's a normal structure. It's just a description that people to understand the anatomy, it was described as a comma sign. So it's not a separate structure or something. It's just a structure connecting your continuation with the subscap to the supraspinatus. So the idea of giving that comma tissue is that when the subscap is retracted, it is retracted sometimes up to the glenoid level. It's very difficult to trace it also. So this is the tissue which is you can easily catch up, and if you try to pull it up, your subscap comes to the footprint easily. So it's just a description as a comma tissue. So it's a normal physiological structure which is connecting the supraspinatus and the subscap. So you don't need to do any separate repair or anything like that. When you do a subscap, when you do a supra, automatically it comes and sits there. It's not a big structure.
Thank you, sir. Thank you. Thanks a lot.
We were about to ask something. So one last question. So that means in your hands, the surgical repair is only for an athletic population with a partial tear. You don't do a surgical option in a otherwise, say, 50, 55-year-old.
No, I think the way to take home message for everyone here is, in the middle-aged individual, like around 30s, 40s, where you think the etiology is degenerative, a lot of the time they will improve with conservative management itself. And he will consider for repair when about 10 to 12 weeks of rehab fails, they continue to have pain and then they will go for repair. But in the young person who has come after a trauma due to an athletic activity, or like a posterior superior tear who are having peel-off lesion along with slap tear, and they are having passer type, but they are like small group of individuals only. So number of repairs I do for partial tear like passer lesion is very, very low. This, if you see, you can count down number of cases like that. So the incidence is very low for inside to repair. I think everybody does in a similar way also. Yeah. Not everyone does inside to repair very calmly. If you are repairing, you can go for a tear completion and repair. That is done most in degenerative case. I do those things only.
At the same point what Subramaniam said, that no, we don't have a very less tolerance to treat this post-traumatic partial cuff tear. We don't need to wait like what Prakash said, that you don't need to have a structural rehabilitation for like a long time. So usually these young patients with a traumatic partial tear, I had seen they don't respond very well to conservative management.
Again,
some more they come with pain.
Partial mean less than 50%, more than 50%? What do you
It's very difficult to measure that 50%. Theoretically we can say 50%, 50%. Anything which is not completely with through and through tear, which we talk about the partial tear. So that patients are young patients. Mostly they are all more than 50% tear. They are not symptomatic. If they are symptomatic, definitely they are all more than 50% tear. So these patients, they don't respond to conservative measures, especially young active patients. Always they come with overactivity pain. Many patients, when they come to us itself, it's 4 weeks to 6 weeks time or 8 weeks time. They don't come on day one. Because many people, they not know that they have a cuff tear, because these patients are treated with X-ray, analgesics, rest. By the time when they come to an arthroscopic surgeon, it will be 4 to 6 weeks time. So if they don't respond, but they will do after 60 degrees, they will have a lot of pain. So that patients need a surgery.
There is one recent trend coming up. If you have more normal tendon than torn tendon, it is a partial tear. If you have less of normal tissue and more of normal tissue torn, it is a near total tear. From a surgeon's perspective, that is more important than 50-50, because it all depends on the measurement pattern. If you have more of normal tendon, it's a partial tear. If you have less of normal tendon and greater tear, it's a near total tear. One more question to Dr. Subramaniam. Partial cuff tear repair is always fraught with severe stiffness sometimes. What are your techniques to avoid post-surgery stiffness if you are doing an in-situ fixation as well as your takedown repair?
When you do in-situ repair, try to do it robust, so that you can start doing rehab very quickly and try to get into their movements very fast. Even if you are doing near completion of tear and repairing, also try to do robust repair only, these kind of cases. And I've seen those patients who are coming for tear completion are all a degenerative group. So you will be excising the abnormal tissue and try to make it like a full thickness tear and do it repair it. In younger individuals, it's a normal tissue is repairing, is rupturing. So you're trying to do inside to repair over there.
Thank you. That was a very wonderful, informative session. The live surgery is going on, but since it's a one-day program, we need to have it as a lunch on symposium kind of stuff. So make yourself comfortable, have your lunch, join us back for the live surgery, but we'll be starting the program now. I request Dr. Clement Joseph and Dr. John T. John to chair the session. Sorry for disturbing your lunch, sir. Please join us for the moderation, and shall we go live to the theatre, please?
Good morning, everyone. Case number 3, we have a 67-year-old male with chief complaints of difficulty in elevation of the arm and stiffness of the left shoulder. He had a history of road traffic accident about 8 months back and history of native treatment. On examination, there's tenderness at the coracoid and long head of biceps. His range of motions are restricted, as you can see in the video. His flexion is around 60, elevation around 60, abduction of 60, and external rotation by the side of around 30. Internal rotation at the back is also restricted. He could reach up to the gluteal region. His cuff strength in the supraspinatus is reduced, 3/5.